Hi, very good morning. I am Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. This lecture will be very helpful to you in your theory as well as oral exam and in your everyday practice when you go for your private practice. So it will be very helpful. We are going to discuss today regarding Bell's palsy. It is also called as idiopathic facial palsy or Bell's palsy. You can see that this is left side. If you see here again, left side, we call lower motor neuron facial, lower motor neuron facial. Again, if you see here, this is on the right side, lower motor neuron facial. Here on the left side, lower motor neuron facial. So when you can't identify the cause, it is labeled as Bell's palsy, or we call idiopathic lower motor neuron facial. So it is called idiopathic facial palsy or idiopathic LMN facial palsy or Bell's palsy. The characteristics of this is it is always by and large unilateral. It is lower motor neuron. It is acute onset, and acute onset means from 4 hours to 5 days, and you cannot identify the cause, we call idiopathic. When all these criteria are fulfilled and does not involve any other cranial nerves, then it is labeled as Bell's palsy. There is no involvement of other cranial nerves, because sometimes you get a lower motor neuron facial along with involvement of other cranial nerves, and it can be bilateral involvement, say like in Guillain-Barré, poliomyelitis, motor neuron disease, sometime even in multiple sclerosis. But this will be pure idiopathic, unilateral, lower motor neuron, acute onset, and cause is not identifiable. There is no apparent cause. So, diagnostic criteria, you have to exclude paralysis or paresis of all group of muscle on one side of the face. It should be sudden onset. There should be absence of signs of other CNS disease and absence of signs of other ear disease. This has to be ruled out. This too has to be ruled out. And it has to be acute onset of non-suppurative inflammation of facial nerve above the stylomastoid foramen, that is in the facial canal, producing unilateral lower motor neuron facial palsy. That is the diagnostic criteria for Bell's palsy. If you go through the etiology, we know that it is unknown. Probable mechanism is some microcirculatory failure of vasa nervosum, or maybe secondary due to viral infection like herpes simplex virus, or maybe ischemic neuropathy, or maybe secondary due to autoimmune reaction. So viral infection, edema and degeneration was common pathophysiology which was put forward, but clinically you are not able to identify the cause. And there is also one theory called entrapment theory, which is because of edema in facial canal producing the entrapment, and the most common virus which is involved is herpes simplex virus. You can have herpes zoster virus, which is responsible for Ramsay-Hunt syndrome, or it can be because of cytomegalovirus, Epstein-Barr virus, or maybe in Lyme's disease. But still, we label that as idiopathic or unknown etiology. Virus that have been linked to the Bell's palsy may be herpes simplex, herpes zoster, Epstein-Barr virus, and cytomegalo. These are the common virus which are, or once in a while, adenovirus involving respiratory tract, rubella, mumps, influenza, and Coxsackie virus. These are some of the viruses which are linked along with Bell's palsy. There are some associated symptoms like Melkerson-Rosenthal syndrome, which is a triad of fissure in the tongue, persistent or recurrent lips or facial swelling, and cranial nerve palsy, eighth cranial nerve palsy. There is a second called crocodile tear syndrome, which occurs due to injury to the facial nerve proximal to the geniculate ganglia. And then, during regeneration, there is a misdirection of the nerve fiber to the lacrimal gland instead of going to the submandibular gland through greater petrosal nerve, and because of this, person will get lacrimation while eating or while smiling. This can be treated by dividing the greater petrosal nerve. So this is called crocodile tears. Ramsay-Hunt syndrome is a herpes zoster involvement of facial nerve leading to lower motor neuron facial palsy. And very rarely you get a bilateral facial palsy due to idiopathic polyneuropathy, sarcoidosis, or occasionally by posterior cranial fossa tumors. So this will be some of the groups, but which is not included in Bell's palsy. The most common cause of Bell's palsy it almost account for 50% of the cases of the facial nerve palsy, that is lower motor neuron facial palsy. Almost 50% are Bell's palsy. Age is between 25 to 30 years. Male to female ratio is almost 1:1. Both sides are almost equally involved, either left or right. But good number of time it is unilateral, more common than bilateral. There's an increased risk during pregnancy, almost it is 3.3% more times. And person who are diabetic, it is almost 4.5 times. Recurrent rate are almost 10%. And 60% has got previous URTI, upper respiratory tract infection. The pathophysiology, we have already explained that exact pathophysiology is not known, but it is believed to be probably because of viral infection, edema, entrapment, and leading to degeneration. And the commonest viral infection is herpes zoster, herpes simplex, maybe because of cytomegalovirus or Epstein-Barr virus, and that may lead to now degeneration. So it is idiopathic, very commonly because of herpes simplex, and it is also labeled as herpetic facial palsy. Most common form of lower motor neuron palsy. It is always sudden onset and there is no other neurological abnormalities. As far as clinical features is concerned, major features of Bell's palsy, it can occur at any age, at any time, but by and large it is between 25 to 30 years of age. It is unilateral lower motor neuron palsy, acute onset, right from 4 hours to 5 days. Peripheral facial palsy, there will be Bell's phenomena, and person may complain of pain behind the ear. You can see on this particular person, if you look at the level of the eyebrow, they are nearly same because the person is looking straight. The nasolabial fold on this side, you can see much better than on this side. The nasal part is little drooping down. This angle of the mouth is drooping down. And if you look at the eye fissure, this is little bigger. Person has got inability to close the eye. So there is no furrowing, There is inability to close eye, and these facial muscles are also involved. So complete half of the face, lower motor neuron palsy. And same person, you can see now when he is trying to smile, you can see this is lifted up, very nice nasolabial fold, angle is drooping down, this nasal part is drooping down, no nasolabial fold scenes, eye cannot close properly, lower motor neuron facial on this side, and no exact cause identified, we'll label that as Bell's palsy. So the major features of Bell's palsy: unilateral, absence of forehead furrowing, no nasal or loss of nasolabial fold, dribbling of saliva or fluid or food from the side where there is an involvement from the angle of the mouth, lacrimation, inability to close the eye, and hence there is an overflow and there will be excessive lacrimation because eye cannot be closed, hence it is exposed to external environment, drooping of the angle of mouth, cannot blow the cheeks, acuity of hearing may be affected because of involvement of the nerve to stapedius muscle. Bell's phenomena will be seen when the person tries to close the eye tightly, eyeball rolls up, that is called Bell's phenomena or Bell's sign. Person might complain of little pain behind the ear at the mastoid process, and there will be loss of taste sensation on anterior two-thirds of the tongue, which we call as ageusia. All these findings may be seen together in a person with Bell's palsy. We already told you unilateral, acute onset, peripheral, Bell's phenomena, pain behind the ear. So unilateral involvement, inability to smile, inability to close eye or raise eyebrows, whistling is not possible, that is pursing of the lip and blowing of the cheeks is not possible, drooping of the corner of the mouth, inability to the close eyelid is called Bell's sign, and while closing that eyeball rolls up, that is called Bell's phenomena, inability to wrinkle the forehead, loss of blinking, slurred speech, or person will have a dysarthria, mask-like face because that side cannot contract, and loss of alteration of taste. Loss of taste or alteration of the taste because anterior two-thirds of the tongue is being also affected. Taste sensation is affected. So already we have discussed pain behind the ear, taste sensation and hearing is affected, inability to raise eyebrow, inability to close the eye on the affected side, flattening of the nasolabial fold, accumulation of food inside the cheek and dribbling of saliva and dribbling of the food material, drooping of the corner of the eye and dribbling of saliva, all these are together. And test what we do. You ask the person to wrinkle the forehead, wrinkling of the forehead will be absent, closing of the eyelid will be absent. When a person is asked to have a wide smile, you will be able to see that one side there is no nasolabial fold seen, drooping of the angle of the mouth, that will be one of the signs which will be available. And when person is asked to whistle, he will not be able to purse the lip and blow the cheeks. So whistling will be also difficult, and by blowing the cheeks, blowing of the cheeks will be also absent because buccinator, orbicularis oris and zygomatic muscles are involved. These are all the different tests you can do. We already mentioned all these findings. You can see here this is a typical Bell's phenomena. Person is asked to close the eye tightly. On this side you can see the person can close the eye tightly. Nasolabial fold is prominent. Furrowing of the head is there. There is no furrowing. Eyebrow cannot be lifted up. No, almost no nasolabial fold. Angle of the mouth is drooping down. Even this nasal part is drooping down. And eyeball is rolled up. This is classical Bell's phenomena and unilateral lower motor neuron palsy. Along with that, lower lid sags and falls away from the conjunctiva. Tear will spill over. Food will collect between the teeth and lips. Saliva will dribble out from the corner of the mouth. and person will also complain of heaviness or numbness on the face. Sensory loss rarely demonstrable, but person may complain of little heaviness or numbness, but there will not be any sensory loss because this particular portion is supplied by trigeminal nerve. So these are all the findings which you can come together. So lower motor neuron facial palsy, palsy with loss of taste sensation in the canal, lower motor neuron palsy plus lower loss of taste sensation plus hyperacusis just after the entrance into the canal, and all of the above plus loss of hearing at the internal auditory meatus. All of the above with lateral rectus damage, cerebropontine angle tumor will be there. In case of damage to the cerebral cortex or corona radiata or internal capsule, it will be lower half of the face which will be involved, which we call upper motor neuron facial palsy, means sparing frontalis belli and orbicularis oculi, and it will be on the opposite side of the face. So if you come across complete half of the face, means frontalis belli, orbicularis oculi and all the other muscle of lower half of the face involved, means absence of nasolabial fold, drooping of the angle of the mouth, this will be lower motor neuron facial palsy, classical in case of Bell's palsy. While in case of a damage to the pyramidal tract at cerebral cortex or internal capsule or in between the two, that is corona radiata, or in the upper part of the pons or midbrain, it will be involving upper motor neuron fibers and it will be opposite side of the face, lower half of the face. That will be typical in stroke. We call opposite side palsy, lower part of the face involved, sparing frontalis belli and orbicularis oculi. Again you can see here, this is lower motor neuron, complete half of the face involved. Here this is upper motor neuron, so opposite side lower half of the face involved, sparing frontalis belli and orbicularis oculi. Both shown in a single diagram. If you get damage here, opposite half of the face. If you get damage here, complete lower motor neuron, means complete half of the face involved, including frontalis belli and orbicularis oculi. Now again you can see here, this is a lower motor neuron, no furrowing, inability to close the eyelids, no nasolabial fold seen, drooping of the nasal part, drooping of the angle of the mouth, no expression, inability to blow the cheeks, inability to whistle, etc. Complete half of the face, lower motor neuron, it will be in favor of Bell's palsy. So you will have to ask the person to show the teeth, open his mouth, close eye, frown, wrinkling of the forehead, raise the eyebrow, then blowing of the cheeks, pursing of the lips, whistle, etc. You will be able to find out whether it is lower motor neuron or it is upper motor neuron. So here you can see absence of furrowing, inability to close eye, nasolabial fold is not seen, drooping of the angle, drooping of the nasal part. You will call lower motor neuron facial. So paralysis of facial muscle, half of the face, smooth forehead, inability to close the eye, drooping of the nose, corner of the mouth is drooped, so angle of the mouth is drooping, and smooth face, no nasolabial fold. You will label lower motor neuron facial. Again you can see this is classical Bell's phenomena. When person is asked to close the eye, person is unable to close the eye and eyeball rolls up. This is typical phenomena we call as a Bell's palsy. Here you can see that the person fissure remains open. Here you can see the wrinkle. You can see the wrinkle. Here the eyelid is closed. Nasolabial fold is nicely seen. Here you can see the nasal part is drooping down. This nose is drooping down. The angle of the mouth is not seen here in this photograph, but you can see that the nasolabial fold is less prominent. This is lower motor neuron facial. This is lower motor neuron facial. You can see again here, the eyeball is rolled up, angle is drooping, nose is drooping, no nasolabial fold, no furrowing, inability to close eye, Bell's phenomena, classical in case of Bell's palsy. Again, you can see Bell's phenomena very clearly. Absence of nasolabial fold, angle is drooping down, no furrowing, classical lower motor neuron palsy. And if you can't identify the etiology, it will be Bell's palsy. Again, you can see here, no furrowing, inability to close the eye, no nasolabial fold, drooping of the angle of mouth, drooping of the nasal part. This is lower motor neuron on this side, Bell's palsy. While here, this particular part, no nasolabial fold, drooping of the angle, lower half of the face involved, sparing frontalis belli and orbicularis oculi, upper motor neuron. And this will be because of damage to the left side. This is right side, lower half of the face, so damage will be to the opposite side pyramidal tract, above pons. We call supranuclear part of pyramidal tract. Both side nasolabial fold absent. It could be bilateral lower motor neuron palsy, or can be also, in case of Parkinsonism, we call expression like face. This is bilateral again, bilateral nasolabial fold absent. Furrowing is nearly absent. Now you will be able to see that when you ask the person to close the eye, on both sides, nasolabial fold is absent. Mouth remains open. No furrowing. Eyebrow cannot be lifted up, so frontalis belli is involved. Orbicularis oculi is involved, and all the other facial muscle are involved. This is bilateral lower motor neuron. Here you can see that this angle is lifted up. Eyebrow is lifted up. Eyebrow cannot be lifted up. Angle is drooping down. This side lower motor neuron. Now if you see here, this is drooping down. Eyebrow is lifted up, means frontalis belli is working. Lower half of the face involved. This is upper motor neuron on this side. So damage should be to what we call as left side of the pyramidal tract. Left pyramidal tract. Again you can see here, this angle is drooping down. Eyebrow cannot be lifted. So lower motor neuron on this side. Now if you see here, this particular side, angle is not lifted up. You can see eyebrow is lifted up, so lower half of the face involved. So now right side, upper motor neuron. So, sorry, right pyramidal tract, left side, upper motor neuron. Occasionally you can have atypical Bell's palsy, which can be slower onset, bilateral, recurrence, and numbness is not unusual. Progression beyond the 7 days suggests any other etiology. Look for that. There is one condition where you get this crust formation secondary due to herpes zoster, and if you get involvement of the lower motor neuron facial, typical Bell's phenomena, angle is drooping down, no nasolabial fold, no furrowing. This will be classical Ramsay-Hunt syndrome. Now this particular part I have already discussed in facial now. So rapid onset over few hours, Bell's palsy. You can do electrodiagnostic test, and then you can go for eye care, physiotherapy and psychological support. As far as treatment is concerned, prednisolone can be given in tapering dose within 72 hours of onset. If does not give benefit, you will have to go for physiotherapy, psychological support, and very rarely you require surgical intervention. If evaluation is very gradual, always try to find out the cause. Because in this rapid onset within few hours, that is we usually mention 4 hours, then always suspect Bell's palsy, while if it is gradual onset over a longer period, try to evaluate like tumors, etc. Very rarely we require a lumbar puncture or MRI for Bell's palsy to rule out. But to rule out the other etiology, lumbar puncture and examination of CSF analysis, MRI to rule out mainly compression syndromes or 8 cranial node tumors, etc. or stroke, that is upper motor neuron facial, that is lower half of the face due to damage to opposite side pyramidal tract. Bell's palsy is always a diagnosis of exclusion, so always examine properly and rule out other causes. Management, glucocorticoids, antiviral drugs, protection of cornea, and very rarely you require a surgical intervention like gold plates in upper eyelid, facial nerve decompression, and physiotherapy will be needed if person doesn't recover completely by pharmacotherapy. You might require a physiotherapy and that will help you out. So in medical treatment, or we call pharmacotherapy, steroid, antiviral drugs, multivitamins, etc. Those are all utilized, but steroid is very beneficial. An antiviral drug may be of use if you pick up the diagnosis of viral involvement. Physiotherapy, they have even tried hypobaric oxygen, and you will have to protect cornea. So anti-inflammatory drugs, steroid, physiotherapy, and electrical stimulation becomes the prime treatment. The commonest antiviral drug which is being utilized is acyclovir, glucocorticoid, and you protect the cornea. And then if there is a compressive symptoms, you might have to go for decompression, that is surgical intervention, and that can be identified by nerve conductions. There are a lot of controversy in the treatment part. Symptomatic treatment mainly to protect the eye, and physiotherapy. Prednisolone is always given in a tapering dose as early as possible. You taper off very rapidly. Decrease the possibility of permanent paralysis and decrease the edema in the facial canal and decreases the severe pain also. So medical treatment, nursing treatment, that is physiotherapy, etc. In surgical intervention, decompression may be tried in some of the people. It can be internal decompression, external decompression. Very rarely anastomosis and reanimation can be done. Occasionally you can go for nerve grafting. We already mentioned glucocorticoid, antiviral drug, protection of cornea, gold plates. Now that particular gold plates is put in the upper eyelid, so because of the weight you can close the eye, so damage to the cornea can be prevented. So gold plate is put in the upper eyelid. Also they do platinum, gold, etc. So because of the gold weight, now eyelid can close. Eyelid can close. Complications, very commonly you will come across loss of taste sensation, ageusia, corneal infection, corneal ulcer, keratitis, etc. are very common because the eye cannot be closed. So you will have to protect the eye, that is cornea and sclera part you should have to close. Occasionally person gets a facial spasm because of abnormal innervation of lacrimal gland. You can have crocodile tears, or also called as a Bogart syndrome. or lacrimal reflex. So whenever person tries to chew or eat, person will have tears. That is called crocodile tears or Bogart syndrome, or even it is seen with smiling. Once in a while you can have, because of the wrong renervation, synkinesis. Means when you try to open the mouth, you will have a movement, or when you close the mouth, you can have abnormal movement of the face, facial muscle, tics, spasms, contractures can develop, person can have a partial recovery, there can be gustatory sweating. So when a person tries to chew or eat, you will have sweating, that is called gustatory sweating, or also labeled as a fresh syndrome. And because of that facial abnormality, person will have a psychological problem, social problems, etc. Now this is that particular we have already mentioned, that is crocodile tears, synkinesis can be seen. So whenever person synergy, look out for closure of the eye while attempting the facial expression. So when person tries to smile, the eyelid will close. So this is synkinesis. So that can happen. Here you can see very clearly. Symmetry of the mark attractiveness will be there. Persistent asymmetry will be always be present whenever person will try to smile. So that can be also one of the problem. Asymmetrical face, and this is now symmetrical. So I end my lecture here. This lecture will be definitely helpful to you in your oral exam as well as theory, and also during your private practice. So thank you all for taking out time. I know that your time is valuable and I appreciate you for spending some of the time with me. See you in next lecture. If you like this particular lecture, please don't forget to press button like. Give your suggestions so that I can improve and I can make it as simplified as possible. So your suggestions are welcome. And if you feel that this will be beneficial to your friends also, you can share with your friends. See you in next lecture.